on the series. And as Dr. Reddy has told you, actually these have generated a lot of interest and a huge viewership across the Asian side. And that's the reason why we thought we'd have a concluding session of this, wherein all the senior moderators who moderated these sessions could give their collective wisdom to this and end this series.
Thank you, GB. So now we come to the actual business of what happened. The first of the series was moderated by Dr. P.N. Rao, who is Chief of Hepatology at our institute, and this was mainly based on diagnostics. We thought we got everything clear in the diagnostic, but the several controversies that came up. The most important of this was RT-PCR. So we'll ask P.N. Rao, based on what was discussed and what is the evidence, and of course what our experience in the institute is, what are the pitfalls in interpreting COVID PCR reports, and what is the significance of CT value in PCR? Not CT value of CT, but CT value of PCR.
Thank you, Dr. Reddy, and thank you very much, and thank to you and GB, because for non-COVIDians like us, it has given an immense opportunity to deep go into this particular area. And as we all know that the first starts with a symptom, and the next thing is to do the RT-PCR. The RT-PCR refers to reverse transcriptase polymerase chain reaction, and this is directly detects the genetic material in the virus. And when we do it, then it comes either a positive or a negative, but there are different challenges are there as how to interpret this one. Suppose if it comes positive, then it is what? Usually false positives are very rare with this condition, unless there is some amount of a contamination with the reagent in the lab or some kind of a false labeling. Otherwise, as you can see, if it's positive, means it's usually positive. But the main challenge occurs when it's become negative, and it's all known that at least about 10 to 15% of the samples would be negative, although the patient may be suffering from the COVID disease. So which are these challenges which we have? The first thing is when you have taken, that's the first thing, because there is been an incubation period of 5 days before which the test becomes positive. Suppose if somebody goes and then sees someone who is positive or who turns out to be later positive, and then immediately on the same day he gets an RT-PCR positive, it is bound to be negative only. And therefore a negative test does not rule out, and it has to be repeated after some time. If the symptoms occur, it has to be done. Second thing is that where you have taken from. Suppose we take from nasopharyngeal, oropharyngeal, and how it is taken. You know that some people have got a very low threshold for nasopharyngeal and then oropharyngeal. They withdraw their face immediately. Obviously, the RT-PCR depends upon the amount of the virus which is present in the sample which you have collected. And suppose if they withdraw their head and the sample is not enough, it is bound to be negative. That's the second most important thing. And third thing is where you have taken from, again depends, the differential shedding of the virus from the upper GI tract and the lower GI tract. After some time, the virus settles in the lower GI tract, when the symptoms progress, then upper GI tract, like the throat samples, can become negative. And lastly, if a mutation is occurring in a general population as such, that's not a very common problem now. If the mutation occurs in the society, then again the RT-PCR is bound to be negative. The next question which people usually look at is that the CT values. CT values is the number of PCR cycles by which time the virus gets detected in the test. But the higher the value, lower the amount of a virus which is present, and the lower the value, the higher is the viral load is present. But unfortunately, this is everybody is, the moment you tell them, RT-PCR, what is the CT value, they go about that one. But unfortunately, the CT does not, it has got its own implications, because from kit to kit the CT value differs. From oropharyngeal to lower it differs, and therefore even our ICMR also has given a very clear guidelines. If you read the lower bottom of any report of an ICMR report, the recognized report, you will see that we should not be serious about thinking about the CT values, and also you should not interpret the CT values in terms of clinical condition. Basically it amounts that after it's positive, one has to closely follow up for the symptoms. Yeah.
Thank you. So in essence, negative PCR does not rule out a disease. Clinical suspicion is strong, and repetitive clinical suspicion is strong. So I'm a bit surprised about the CT value, because so much of importance is given to CT value. So you're telling us not very important. We don't have to totally depend on that.
Yeah, different kits will have a different CT values.
So I think you have to be careful about, you must use the same kit, and if your lab is consistently doing the same thing, then I think you can follow your lab. Otherwise, one should not blindly go by CT value, because a lot of doctors say my CT value is low. I think I got a very serious illness, so that may not be in all the cases.
And also, if you see across the globe, the kits which have been used, they're targeting different antigens in the gene.
Yeah,
In
so
USA it is
another
different,
important
in
point.
Japan it's different,
Yeah.
in Thailand it is different. And also if it is negative by one particular cat, if your symptoms are very high, then it's good to see that another kit you can see that then it may become positive if a different antigen is targeted.
Yeah, so I think it's important that CT value has got some controversies. You told us about the RT-PCR. Thank you very much, man. So we then come to the second session, and the second session was moderated by Dr. Sandeep, who is head of our endoscopy unit. Now, this session was on face looked very light. It's only about mild disease or home care and all, but the most controversies are probably generated in this area. So, Sandeep, everybody who's in their home are told to take antibiotics, ivermectin, vitamins, and so on. What is the role of all these agents? Because we look at evidence-based, no role, but almost 100% of the people are taking these medications.
Yeah, thank you, sir. This is a very, very important question, as 80 to 85% patients are asymptomatic. And once you tell them that they have the disease, which is mild or asymptomatic, what is to be done to them? And if you don't give any medicines, it's a common thing that a person would understand why I'm not getting any medicines. We just tell him, if you have fever, take paracetamol and monitor your oxygen level. If it drops below 95, then you need to be more alert and go to a hospital, because majority would get well at home, and that's where home quarantine is important. But what to do during this period is little controversial, because the standard prescriptions which are running all over the country, from a Dr. X to a patient 1,000 kilometers away, contains many medicines, which includes commonly antibiotics, which are generally not advised. Antibiotics are antibacterial agents and they do not have any effect on the virus. That's a very common misconception. People say that if you give an antibiotic, if there's super infection, it will help that. But probably we are doing more harm than good, because it's unnecessary and also causes drug resistance. And if these bugs become resistant, then next antibiotic which will be much stronger and may not be effective. So antibiotics have no role unless we have a proven evidence of a bacterial infection in a patient who has a viral disease. That's one. The commonest antibiotic which have been used is azithromycin and doxycycline. Both have been found to be little effective in vitro studies, but not on an objective and a clinical studies. So net, I don't think there's any role of antibiotics per se. The next important thing that people are given is very high dose of vitamin D, almost as if people are suffering with vitamin D deficiencies. And studies now have shown that those who are deficient or having less concentration of vitamin D in their blood do not have a higher chance of acquiring infection, or those who have an infection are not seriously predisposed to a severe disease. So again, net, there is no scientific reason to give vitamin D in excess. And if people just sit in the sun for 15-20 minutes, that will give a good amount of a natural vitamin D which is available to us. The third thing which has been tried very often is again vitamin C, as if we are suffering from scurvy. No, we are not. If somebody takes a normal dose of fruits and vegetables, which are quite rich in vitamin C, we don't require an extra source of vitamin C. There are a lot of theoretical explanations going around that it helps in prevention of viral infection, has an antioxidant effect. Those are theoretical, but never has a clinical correlate to that. So vitamin C along with zinc also have not found to be effective in worsening the disease or prevention of worsening the disease, or even in duration of hospital stay. The last, which is the most controversial, is ivermectin. Ivermectin has been used for many decades as an anti-parasite agent. How does the anti-parasite agent work for antivirus? Again, there is theory to it that it prevents binding of the virus to the human cells, the ACE receptors. That prevention is one of the premise on which ivermectin has been tried. but again, it has not been found to be useful. However, there are some studies which support it, mainly from India. There's a study from AIMS Bhubaneswar and AIMS Patna, where they've showed that if you use ivermectin as a prophylaxis for healthcare workers, you reduce their chance of getting infected if they're working in the COVID ward or COVID exposed areas by about 75%. But another way around, there are studies from Brazil which have tried using this as a treatment part also, have not found it to be very useful. So it's a debatable area. However, ICMR and AIMS guidelines still suggest to use ivermectin as a 12 milligrams per day for 3 days apart for prophylaxis, and daily for 5 days for mild disease.
Thank you, Sam. So you say that mild disease, you're staying at home, don't take anything. There's
So
nothing
reassuring the patient not to take anything, I think that word is much more important than writing a prescription having 10
So
medicines.
isn't it more difficult to reassure a patient than write a prescription?
I think it depends how you communicate with the patient. If you know the patient and he has faith in you, there it works. But if you don't know somebody and is asking for a prescription, then probably that connect is missing.
Thank you. That's a very important point, Sandeep. The take home message that when you're staying at home, don't take anything extra. Just watch yourself and some of the things we have discussed in the previous lectures on how to monitor yourself at home and when to report to the doctor. Our next session, which was moderated by Dr. Rajiv Menon, head of interventional cardiology here. Rajiv is going to take up a very controversial area, I think. Rajiv, the steroid business, there's been a lot of controversies. I mean, everybody says don't give too much steroids. In spite of that, we see people using too much steroids. How do you analyze the problem that's occurring with steroids?
Yeah, I think most importantly, if we talk about steroids, I'm sure the people who listen to the talks, they got a very clear idea about when to use steroids, what dosage to use, which steroid to use. But if there has been one tragedy in this entire pandemic, I think that has been the abuse of steroids. We all know, we have learned throughout our training that steroids have to be used judiciously. And unfortunately, in this situation where few trials which have shown its benefit in the sickest of patients has been extrapolated to the entire population. And the ill effects of that we are seeing now in the form of mucormycosis, the black fungus, white fungus. Yeah, the day is not far away when we start seeing multi-drug resistant organisms. And unfortunately, in the first wave, we were seeing more people dying because of COVID. Now we are seeing more patients dying because of the treatment given to COVID. So that's an extremely unfortunate situation. I think if there is one message from this entire series of lectures which should strongly go into the community, it is to stop the abuse of steroids. Mild cases who don't require anything, we just heard Dr. Sandeep telling don't even give vitamin C and vitamin D. These are the patients who are getting high doses of steroids. Imagine a patient on ventilator who is recommended 6 mg of dexamethasone is getting something like 100 mg of dexamethasone in the OP setting without any symptoms, and all of them are coming back with the complications of steroids, including diabetic ketoacidosis, new onset diabetes, hypertension, multi-drug resistant organisms. It's an extremely unfortunate situation, and I think including ICMR, the government, everyone, the amount of efforts which are being put into convincing people not to use remdesivir and plasma, the same effort should be put in to make sure that the abuse of steroids need to be stopped immediately. At least today, if we stop the abuse of steroids, we might see a change in the complication rate in the next 2 to 3 weeks. And that's definitely going to save a lot of lives. I think it cannot be re-emphasized and overemphasized that the abuse of steroids has to stop as soon as possible.
Yeah, Rajiv, that's an extremely good point. I think steroids, unfortunately the Oxford trial started all this, but they were very specific when to give steroids. In the second week, in moderately sick patients, patients who had hypoxemia, but this has been taken overboard and everybody starts using. So I was wondering whether the government should actually ration steroids like they're doing with amphotericin B, or that they're doing with other drugs, whether they should also ration steroids, and under strict conditions only steroids can be bought from the pharmacies, because India is probably one of the few countries in the world where you can buy steroids right away from the counter. You can't do it in any part, and that's the reason why we're seeing this overuse.
Yeah, absolutely. That is one drug which needs to be rationed, which needs to be stopped. The abuse needs to be stopped. And if there's one place where the government has to intervene to make sure that lives are saved, it's probably stopping the abuse of steroids.
I think that's a very good point, because remdesivir, as you pointed out, although the evidence is not very strong, our own experience in the institute has been fairly good. And there are no side effects with this. So there's no point in trying to ban remdesivir or say it not to be used and then just leaving steroids free, which is doing all the problems. So that's a very good point, and I think all the doctors who are watching this program should take cognizance of this fact, that be very, very careful and use it for the right indication. Thank you, Raj.
Thank you.
So our next topic is going to be connected with steroids. See, this is very not controversial. It's very funny that we say don't take steroids, but there's the inhalation steroids, budesonide, which has been advocated, in fact, found to be useful in very, very early cases. So we'll ask Head of Department of Pulmonology, Dr. Vishwanath, to tell us about this budesonide business. So can we use this? Should we advocate patients to use this?
So, sir, inhaled corticosteroids have got an important role in the, especially in the first week in the mild COVID cases. It's very, very interesting to know how this actually inhaled corticosteroids role came up in the last, I think, 1 year or so. So it has been found in the European cohorts that there is underrepresentation of cases of chronic obstructive pulmonary disease and also of the patients of bronchial asthma. Then they went back and looked at this data. All these patients have been on inhaled corticosteroids. So it was hypothesized that it is inhaled corticosteroids are the main reason why these people have lesser chances of developing COVID-19 infection and also lesser chance of developing a severe COVID-19 infection. And hypothetically, it was proposed that, and it was also in studies, it was shown that patients who took inhaled corticosteroids have a lesser expression of ACE2 receptors. That was one of the reasons why it was thought that these patients have a lesser risk of developing COVID-19 or the severe COVID-19. And then that led to a very good randomized control study, which was published in Lancet a couple of months ago. In this study, which was published in Lancet, which was a randomized control study, they have divided the patients into standard of care who did not receive any inhaled corticosteroids, and the other group received inhaled corticosteroids, and all the patients who came with a mild illness within the first 7 days of illness were included in the study. So in this study, what they have observed is that the people who were given inhaled corticosteroids, especially the inhaled budesonide, 800 micrograms twice daily, had a lesser chance of going into emergencies, lesser chance of hospitalizations, and their antipyretic use was also less. And symptomatically also, the patients reported faster improvement when steroids were inhaled corticosteroids were given.
And these were patients in the home, staying home?
These were patients, they were not given oral corticosteroids. They were only
home
given
care,
inhaled corticosteroids. So the study was actually included 70 patients in both the arms actually. However, the study was prematurely interrupted because they thought that including further more number of patients would not change the outcomes. Then that study came up with a conclusion saying that it would be helpful in mild cases to prevent the complications also. In our routine clinical practice also, what we have seen is that patients who develop severe cough, instead of giving oral steroids, I have used inhaled corticosteroids in my practice, especially the budesonide, and it has helped a lot of our patients actually. So this would be more safer because the chances of absorption are very, very less. Unless you use the inhaled corticosteroids in higher dose, more than like 2000 micrograms, the chances of absorption to the systemic circulation are less, lesser immunosuppression is there.
So you would suggest this. So the summary that seems to be coming out of this discussion is Sandeep says no drugs, which is absolutely right. And you say maximum you can use inhaled budesonide, especially if you have staying home, if you have cough, use this inhalation rather than any other drugs.
Yes, sir. Even in the recently published AIMS and the Ministry of Family Health Welfare guidelines, inhaled corticosteroids, especially the inhaled budesonide, was added. Especially the Indian guidelines recommended using inhaled budesonide for people who are having symptoms more than 5 days, especially the cough and the breathlessness.
Cough is the main symptom.
Yeah, cough is the main symptom.
So thank you, Vishnath, for clarifying that. And then we come to our next question, which is going to be for Manu Tandon, is Director of our Clinical Services. He is actually heads the Asian Institute of Gastroenterology at Somaj. Manu moderated his sessions on vaccinations. There are a lot of questions that came up. But what we are going to ask him is, when is vaccination advised after recovery from COVID? Because we have a lot of patients coming up and saying, I just recovered from COVID, can I take a vaccine? And unfortunately, there's a lot of, I think, changes that are occurring in government protocols. So Manu, what is your opinion?
Thank you, Nagi, both for the opportunity and the question. As Dr. Reddy has rightly told in his introduction, management of COVID is a moving target, and this is one topic, vaccination after COVID, where the jury is still out. International guidelines were very clear that if someone has got COVID, either the first or the second dose is to be taken between 4 to 8 weeks. This was what we thought till recently. On the 19th, that is just 2 days ago, Indian guidelines came from our task force, which are now stated that you need a minimum of 3 months for vaccination after recovery from COVID. Now, it could be the first dose, it could be the second dose. So, Nagi, I think the answer to that question right now is definitely not within 1 month. It could be anything between 2 to 3 months. We probably will wait for a little more data before we can really pinpoint an exact duration.
Yeah.
So right now we are putting a time zone there, Nagi. That is what I think it is.
Thank you, Manu, for that very clear explanation. In fact, at this stage, I'd like to tell the audience that there are 2 very important papers that came out from the research department of AIG. The first one was regarding vaccination following COVID infection, and what we did was we actually looked at all our staff were being vaccinated and if they had a recent COVID infection. And we found that those who had a recent COVID infection, a single vaccine was sufficient to bring very high titers of antibodies. And not only antibodies, the T cell memory cells also increased markedly, indicating that, adding to what Manu said, that maybe a single dose given anywhere between 1 to 3 months is sufficient. If you already had a COVID infection, you don't require 2 doses. You can look this paper up, we'll send you the references. The second important paper that came was published in the International Journal of Infectious Diseases, a high impact again. We showed that what Dr. P.N. Rao was telling us about negativity in the RT-PCR test, and what they found was that if the test is negative, if you add saliva of the patient to this test, then your positivity jumps from 70 to 90%. So for those of you who are getting repeated negative tests, RT-PCR, kindly get one saliva sample from the patient and you're bound to get positivity in over 90% of the patients. So I thought I'll just introduce you to two of these papers that have been recently published from our institute. We go on to the next question, and this is for Anand Gupta. Anand is an intensivist. He's the director of our intensive pulmonology service, hepatology services here. We've been hearing a lot about this prone, and in fact, the first time I heard about prone ventilation was during this COVID crisis. I never knew there was something called prone ventilation. I sometimes try to sleep prone, but I find it very difficult, although breathing becomes more difficult, I thought. But you say that prone ventilation is better, lungs open up. What is the rationale, and what is prone ventilation for the audience?
Thank you, sir. Proning, apart from the medical management recommended in the COVID care, the proning is the most important beneficial thing, sir. Most of the patient improve with the oxygenations, and we can avoid the ventilation also by proning. Proning is nothing, sir. It's just like lying flat on the stomach with the face down, and arms should be extended, and with precisely and safely. So what proning does, sir, in a supinations, when we at a supine position with the patient breath, then abdominal organs just push the diaphragm to upside, so will restrict the ventilations. Along with that, heart is lying on the heart in the lungs, so that's why it compress the lungs, and the posterior part of lungs, which are not taking participation in the ventilations, they also compromise. So that's why these 3 things can be reversed in the proning positions. Once we'll make a prone positions, the posterior part of the lung will ventilate and will perfuse well, and the heart will rest on the rib cage, so that part also will benefit, and then will push the diaphragm to downside, so it will expand more. Along with that, the ventilated patient, the draining of the secretions can be done easily with the pronings. So these things will improve the oxygenation and allow more lung to ventilate. So these things will improve the ventilations and oxygenations.
So Anand, how long should you prone the patient? How much, say in 24 hours, what period should you be in prone?
So if a patient is on ventilator patient, so generally recommended is 12 to 16 hours at a stretch we can ventilate. And non-ventilated patients, like awake patient, awake proning, so there's some time for half hour to 2 hours is a fully prone, then lateral half to 2 hours, half hour to, and then right lateral, and then can be supine. So with this cycle can be repeated.
Okay. Thank you, Anand, for explaining this thing to us. There are a lot of new drugs that have come in, all with NIPs and MABs. In fact, tocilizumab, infliximab, baricitinib, and then we have, of course, tofacitinib, all sorts of names which are difficult to pronounce. So what we did is we asked our most brainy doctor in our institute to try and explain this thing to us. He is Dr. Kalambari's Narsimham, who is head of cardiac electrophysiology, and he'll tell us about what all these things mean.
I think COVID has again taught us understanding the basic physiology and pathology helps our treatment be a lot more specific to the patient, and the treatment can be with relatively fewer side effects. Let me give you an example. In the olden days, when you had E. coli infection, we used to treat these patients with drugs like gentamicin. So when you give gentamicin, E. coli gets suppressed, but you get ototoxicity, you get nephrotoxicity. There is nothing specific about it. Increasingly, we are able to understand the molecule which drives the cytokine storm, for example, IL-6. You know the structure of IL-6. You know how to exactly go and dock into IL-6 and make it non-functional. That kind of improvement has come in the last 20 years. So it can be done by two ways. One is, in the extracellular environment, you can have large antibodies which can go and dock into these receptors. Exactly the same, it's like a key and a lock. If it's exactly in the same structure, they'll go and dock there, and therefore it will be non-functional. On the other hand, there are small molecules, they are called as monoclonal antibodies, which ends with MAB, monoclonal antibodies. Whereas the NIBs or the inhibitors, it is taken from kinase inhibitors. These are small molecules which go inside, less than about 500 daltons in size. It just goes inside the cell. Similarly, they have a very specific function. If it's a receptor or an enzyme or an ion channel, they go and dock there exactly in the same conformation. So if there is a negative charge on the pore, there is a positive charge on this molecule, which makes the binding a lot more specific. It doesn't bind anywhere else, so it's relatively free of side effects, and therefore these small molecules can be the biggest advantages. They can be given orally, and they are relatively specific.
Thank you, Dr. Narsimham, for making it so simple. One of the problems we have found in COVID is that when patients come for surgery, there are several complexities involved. For the surgeons and somebody like GB Rao was to organize the theatres, how difficult it is to organize it. For example, elective surgery, when should we check for COVID positivity before they take up a surgery? Because we've had patients who are negative when they come in, and just before surgery they become positive. There's some guidelines on that. I think the unit has made several guidelines. And we have this problem for an emergency patient, somebody with a perforated appendix or gallbladder, but is COVID positive comes in. So what are we supposed to do, GB?
Yeah, thank you, Nagi. Actually, COVID everybody believes is a medical disease, but surprisingly there's a surgical component to this also. So we have COVID surgery too that happens actually, which runs behind the scenes actually. Now all the surgical patients need to be triaged out as of today. Now triaging means you have to categorize these patients based on whether they require emergency surgery, whether they require urgent surgery, or they require some sort of elective surgery. This triaging is very, very important basically because we have to adjust our resources right now more towards the COVID patients, and then we keep these elective surgical patients for a later date. So for this entire thing, the entire resources that we have in the hospital have to be reorganized, and most of them are diverted towards the COVID care. Now the COVID care, now we have patients who are coming up both for elective and also for emergency surgery. As rightly said, some of these patients come with who are COVID positive, who have some emergency surgery, have to be taken up for surgery. There are some patients who in the perioperative period seem to be turning positive in spite of all the precautions that been taken. Now the protocols have been that actually we usually get an RT-PCR done one day prior to surgery, and this RT-PCR is repeated every 5th day to make sure that we are protecting the healthcare workers from any cross infection that can happen to the healthcare workers. Also, we are also limiting lot of patient families to visit the hospital, visit the patients in the hospital. And as a part of this, we have started doing extensive video counseling for these patients, and we don't see any of the attendants coming to the hospital to visit the patients right now, and most of them are counseled on the online as in today. That's the biggest advantage that you have had. And all the elective patients have been rescheduled, and some of these patients who are turning urgent, actually they are being taken up. But at the same time, this protocol seems to be changing every time. The protocols are dynamic, they're changing every week, every month actually. And actually we've been constantly updating ourselves, these protocols, what have been happening across the globe, the evidence-based protocols. And we have already organized ourselves. We have got designated COVID theaters which are designated to do these surgeries. These are absolutely negative pressure theaters. The theater personnel are trained to move in the theaters actually, and how to take care of these patients both in the pre-operative and the post-operative. And as a specialty by itself, right now we have a separate COVID surgical ICU as in today in our hospital, which is specifically taking care of this post-operative patient. It's a unified effort of the critical care, surgical specialties, and all the other specialties are put together. So a lot of resource management has been diverted. They've been told what their new roles are to take care of this patient, and this has led to very good improvements, outcomes that we are seeing in the surgical patients as in today.
Thank you, GB. So I think for a COVID surgery, we require certain additional things like a negative theater, the pressure negative theaters, we require COVID specific ICUs, and fortunately you could organize all this here. And that I think will certainly make a difference in terms of what happens post-operative mortality, and I'm sure
Absolutely.
there's some changes.
Because we have very clearly shown that the mortality in these patients is slightly higher, and they require very critical care, and the ICU teams are very highly trained to do this, and they're taking care of this. And then we have seen that the mortality is quite low in our center especially.
Thank you, GB. Another new word that I learned during COVID was this so-called high flow nasal catheter. I didn't know about this till COVID came in, and suddenly in the beginning of COVID, all our intensivists came and said we require 30 or 40 of these HFNCs. I said, what is HFNC? And they said it's a high flow nasal catheter which can deliver up to 40 or 60 liters of oxygen per minute. So I will ask Shiva Prasad, our Director of Intensive Care, to tell us about this HFNC and how useful is it in COVID. Should all the hospitals actually put in their money into this?
Yes, sir. Thank you for providing this opportunity, sir. HFNC is a specialized device to deliver high flow oxygen to the patients. It's nothing but delivery of oxygen. This device does something unique, is that it delivers a very high flow, thereby the patient's oxygenation can be better compared to the other conservational oxygen delivery devices. So what this does is, it creates some sort of a splinting of the airways and then opens the airways, creates some sort of PEEP, and thereby the patient can have a comfortable breath and then increases the saturations. Not only that, it also helps in providing a proper humidified air, because the air being provided through HFNC is always humidified, and that will be comfortable for the patient. So any patient who is not having an increased work of breathing, who's comfortable or having some sort of happy hypoxia, this device can be used for them. And with this device, we can deliver somewhere around 60 liters of per minute of flow can be delivered, and also around 100% of oxygen also can be delivered.
Yeah, but Shivkumar, if these oxygen shortages that we are having, what do you think the current role of this device?
Yes, sir. Yes, sir. There are some caveats which I was coming to that. There are some caveats with HFNC. That is, it requires a very high oxygen flow. So that's the reason why a lot of small centers cannot use this HFNC devices in large numbers. Maybe one or two, the oxygen runs out very fast. So this device probably has to be used at centers where the oxygen can be produced in large scale. So that's one thing. And one more biggest caveat of this particular thing is it requires some training to use this particular device. Else what happens is the patients who are using this HFNC devices can have burns, because if the humidifier is not provided appropriately, it can cause significant burns. So all those caveats should be in mind whenever we are using it. And also this has to be used as a step-up protocol. First thing is, First, we have to try with our conservative oxygen delivery devices. Only if that is not successful, we have to consider HFNC. And if HFNC is not successful and work of breathing is high, maybe NIV. And even if NIV is not appropriate, then for ventilation. This has to be the step-up approach for treating any patient.
Thank you, Shiva,
Yes.
for clarifying that. So basically, HNFC is for patients who are in happy hypoxia and centers which have trained personnel enough oxygen to use this. Thank you very much. So we come to another important problem that keeps occurring, and people tell us, my friend had COVID last year and has got back COVID again. So we'll ask Dr. P.N. Rao, who chaired this session, whether recovery from COVID actually protects against another COVID.
Yeah, as you said, it's a very important question which we frequently come across from our patients, and one has to see that the reinfections do occur, but they are not very common. This one across in the ACMR study has shown that in a prospective study which they have tested about nearly 1300 patients, they got about 4.5 persons have got reinfected. But across the globe is slightly higher, about 10% to 10 to 15% they can get reinfected. But the crux of the question is that what is meant by reinfection? That is very important to tell us, because reinfection, just because the RT-PCR has become positive, it does not mean that it is a reinfection, because NIH guidelines and also prospective studies have clearly shown that the RT-PCR can be positive even up to 90 days after the clearance of the first infection. And we commonly we keep seeing, somebody has got an RT-PCR negative by about 15 days, somebody got it negative by about 35 days, and that does happen. So what is meant by actually the reinfection should be, if at all one wants to say that theoretically for the reinfection, one has to do the molecular test, but it's not possible in a practical situation, ground situation is not possible to do. And also you do it the first time and also the second time to see that the reinfection has occurred. Barring that, as a thumb rule, it has to be after 90 days. If two RT-PCRs are positive, one in the beginning and one after, with one in between RT-PCR negative, then it is called a reinfection. In the recent ICMR data, it has been shown they have taken about 102 to 160 days for the duration from the one test to the other test, and therefore they concluded that they didn't do any molecular test, but they concluded that it is a reinfection occurring about 5% of the Indian. And another very important here to that, the reinfection when it occurs is always usually milder in the nature.
I think these are two very important points you clarified, that we have to define reinfection. That is, there should be a gap of 90 days between both. Otherwise, it could be the RNA going on. In fact, the first reinfection case was reported from Hong Kong. The single case became a report in New England Journal of Medicine because it was thought it was so important.
Yeah,
but of course, they did a genomic sequencing
right.
there from before and second month, so they could demonstrate it. So reinfection is not common. Luckily, it's very small percentage if it occurs, and even if it occurs, it is very mild. That's the message we get from Dr. P.N. Rao's summary.
In fact, the NIH guidelines say that you should not repeat the RT-PCR within 90 days if the person is asymptomatic.
Yes.
If he's become symptomatic, which has nearer to the COVID infection, then only you should need to repeat.
So because this was another confusion that occurred, whether we should do a RT-PCR after 14 days to show somebody is negative or not. So we believe there's no necessity. If the patient is asymptomatic, it's not necessary to do anything. Just
and another thing is that they will lose the replication fitness even if it is there. Replication fitness, that is ability to replicate and then multiply,
after 14
is
days.
very, very low.
Okay.
After 10 days of an asymptomatic period, cases, and after 20 days after even the severe cases also, they won't replicate.
Yeah. Thank you, Pen. So I think we'll continue our conversation with Sandeep on the home stay, and you said nothing to be done. But I believe one of the drugs which is the most maximum used in this is favipiravir. It's been used extensively by practitioners, by sometimes patients themselves. So what's your opinion on this?
Favipiravir is the only antiviral drug which has been approved. It came very early in the course of pandemic of COVID. It was first approved in Japan and then quickly approved by some of the other national guidelines from Russia, Thailand, Saudi Arabia, and even India. It was quickly made by many of the pharmaceutical companies. So that was one bright spot which happened. Unfortunately, the use of favipiravir is mainly for mild disease. It prevents the replication of the virus by preventing that enzyme which is crucial in replication, RDRP. But it has not been found to be very useful in severe disease. Doesn't reduce the hospital stay, doesn't reduce the requirement of oxygen on patients who are requiring high dose of oxygen, NIV or ventilator. So this drug came with a bang. There's still trials going on whether it should be used. It is still recommended by some of the international guidelines. Strangely, the ICMR AIMS guidelines does not recommend favipiravir, whereas the COVID protocol from the national experts recommends that. So there is a little bit of conflict within India too, whether we should use favipiravir or not. Having said that, it is probably useful in mild disease, gets the RT-PCR quickly negative in patients who are continuing to have symptoms. Even the chest symptoms or CT changes also recover a little faster in people who have used this. There are some little issues also with favipiravir is that the adverse events. There are few adverse events which are quite common, and we often see in the GI practice that people get diarrhea. Diarrhea is one of them, and second common thing is abnormal liver function. So it's virus which is causing liver function abnormality or drug which is caused. It is sometimes difficult to dissect. So withdrawing the drug and we see improvement in the patient, that helps us. Some other things which can happen is like rise in uric acid, bradycardia, even WBC count can go down. So those things have to be used in with caution when we find these changes in labs or in clinical scenario.
Thank you, Sandeep, for that very measured answer. I think this actually answers a lot of things, especially for the practicing doctors, when they should use it and so on. So we come next to a very common problem we've been facing, and this is actually the patients coming us or sometimes doctors ordering the CT chest. Very commonly, there's a lot of confusion. Our radiologist, Dr. Tarini, gave a very good, nice talk on when to do CT chest and so on. But what we'll do is we'll go to our physician, Dr. Jagdish, who's one of our internal medicine consultants, who's got huge experience with COVID. We'll pick his brains for his distilled wisdom on what we should do in terms of CT scan in patients with Jagdish. ప్రింట్అవుట్ ఇస్తారు
huge importance particularly to COVID because it's not even one second gold standard biological assay or the test which is giving 100% accuracy. So definitely coming to microbiological tests, not even one test could give you 100% accuracy. So it is the need of the hour that we have to depend on biological imaging. When we have to do the test, many of the times a lot of people have this confusion in spite of getting RT-PCR positive, they happen to run for a CT scan. So I think this is one thing everyone has to understand. The CT scan is not mandatory in COVID, but if a doctor assumes that a CT scan is needed either for the prognostication or to identify anything else what the doctor is thinking in that particular case, the CT scan is needed. But when it comes to diagnosis of COVID, so many of the times the patients are symptomatic, they have 2-3 days of fever, they go get antigen test or RT-PCR. In spite of getting RT-PCR and rapid antigen test negative, still you could have COVID. So this particular cases, we call it as rather RT-PCR negative COVID cases. I think CT scan is much useful, but there is a condition here. CT scan before 5 days, most of the times it may not be you may not pick anything in the CT scan. I think ideal time to get a CT scan in terms of diagnosis should be from day 5 to day 7 of the symptoms, first day of symptom. In terms of prognostication, or either we are identifying any pulmonary embolism, I think any part of the disease we can go for a CT scan. So particularly diagnosis, I think everyone should try to avoid a CT scan within the first 5 days. Because most of the times a CT scan will be nil.
Thank you, Jagdish, again for being very clear on this, because this controversy has come up because the director of AIMS recently said that CT scan produce cancers, and the Radiology Association put up a statement saying that this is not true. Controversy is going on even in public. So you are very clear that CT scan should be used very judiciously, not definitely very early on because there's no use. It should be used only in the second week when you are trying to prognosticate the disease, or if you suspect pulmonary thromboembolism and so on. So these are very clear messages.
It is a doctor's call rather than the patient's call when it
Yeah.
comes to CT scan.
So very important. So when a patient comes and tells the doctor, get a CT scan done, try and explain to him that is not necessary. It may be harmful more than it actually benefits. Thank you. Thank you, Jagdish, for confirming that. And one of the common things that we hear is that a young patient suddenly came to hospital and collapsed and died. His ECG taken at the acute period is sometimes abnormal. So we'll ask Rajiv Menon from our cardiology department, how does COVID affect the cardiovascular system? In general, the coronary arteries get blocked with COVID?
Yeah, so I think one statement which can be mentioned about COVID and cardiovascular disease is partners in crime. So each one actually aggravates the other and rather kills the causes death of the patient by aggravating the whole situation. If we just look at the numbers, the chances of developing a thrombotic event, a cardiovascular thrombotic event, is close to 7 to 10 times than in a normal population. So a patient with COVID has a 7 to 10 times higher chance of developing a cardiac issue, either a acute MI or a stroke or a thromboembolism, what we refer to as blockages in the pulmonary arteries or blockages in the leg arteries, blockages in the leg veins. This is nearly 10 times higher. Similarly, the chances of myocardial injury, direct injury to the heart, again is quite high, almost double. Now, it doesn't end there. A person with COVID who actually develops acute MI, the chances that he will not make it is nearly 10 to 15 times more. So, just to give you numbers, suppose the mortality risk with the acute MI is around 4%. A person who has COVID, the risk is close to around 40%. So, that's huge. We have never seen 1 in 2 or 1 in 3 people dying of acute MI, but we are seeing that in COVID. So it's extremely important that in these situations, patients who have risk factors and patients who are at a higher risk of developing clots, it's extremely important that they take adequate precautions. And if they get COVID, make sure that you consult your physician and get the appropriate therapy. Now, having spoken about all the negative aspects, one silver lining is now there is recent data to suggest that if we use statins, the chances of developing these thrombotic events come down. And luckily for us, there is also emerging evidence that if we give statins, the chances of developing mucormycosis also comes down. So both ways it's going to be helpful. So we would suggest that in patients who have risk factors or are above a particular age or who already had a coronary event, it's extremely important that all of them should be on statins, and statin should be considered as one of the drugs for COVID rather than a cardiovascular drug which should be added to the COVID medications.
Okay, that's again, I think, a very important point, that instead of using all these dangerous drugs, a simple statin may help these patients. And if a young patient comes with, say, severe chest pain, suggestive of myocardial infarction, but COVID is positive, would you go for a primary angio and then see if you can? Is it worthwhile doing that?
Yeah, so there are a lot of guidelines which have come up since last year, European, American, even Indian Institute, different institutes have come up with the guidelines. In AIG, we make sure that all patients we take up for primary angioplasty. There's no reason not to do so because you can go ahead with all the routine precautions. Most of the things are standardized. So we make sure that a patient who is COVID positive, who develops acute myocardial infarction, is not treated in a way different from a normal person who has developed acute myocardial infarction. 100% of our cases have been taken for primary angioplasty. We have data of around 20 patients who developed acute MI with COVID. The issues are the risk associated with COVID per se and the risk associated with acute MI. So by doing primary angioplasty, at least we are able to take care of the risk associated with acute MI. Of course, COVID, we need to again follow the standard protocols and hope for the best. So 100% of our cases we take up for primary angioplasty. In our institute, the indication for thrombolysis is actually massive pulmonary thromboembolism rather than acute MI. We get a call from ER if we say thrombolysis for acute MI. they'll ask us, why are you not doing primary angioplasty? So that's standardized.
Okay. Thank you, Rajiv, for confirming that. And we have in our institute, we have a very busy liver transplant unit and a brilliant liver transplant surgeon heading it. In fact, even in this COVID era, Dr. Balachandra Menon is doing a lot of liver transplants. And whenever I try to reach him, they say he's busy in the theater doing a transplant. So because of his huge experience, he's published a lot on liver transplant and COVID also in American Journal of Transplantation and so on. So we'll ask Bala, what is his experience, large experience? I'm not sure that many people in the world, even in the liver transplant field, have this experience you have with COVID and transplants. Can you tell us the experience?
Thank you, sir. Actually, COVID times have been pretty difficult for surgeons. We have had actually the cases which come up for transplant are extremely sick. It's only mostly the acute and chronic liver failures only end up for transplant. It's not only the surgeons, the entire family also has a lot of trouble arranging blood. The logistics are difficult. Arranging finances have been a big task. So ultimately what we have ended up during this last year and a half has been extremely difficult cases, pretty sick, and lot of patients we actually happen to lose on the waiting list. But if you look at the patients and whatever literature we have, the patients have behaved probably better than the general population. There have been 3 large studies in the early part of last year, one from Spain during the height of COVID infection there. There were about 111 patients. Surprisingly, the patients showed the same amount of infectivity, but the mortality rate was lesser. And there have been 2 more studies, both in Lancet Gastroenterology and Hepatology, both from Europe and multicentric, and both had actually acquired patients from 18 centers, both had about 150 patients. The first one actually came in the June 2020, where they actually looked at patients who were transplanted more than 10 years back. And what they found was the mortality was directly proportional only to the comorbidities. There's another study which came up in the same journal in February. This also showed that actually the results, the mortality is probably less as compared to the general population already, although they probably required more oxygen support, more amount of ICU care. Now, in this last 1.5 years, in the last 1 year actually, we just looked up at our data, we have done 95 transplants, out of which about 70% were ACLFs. And the average meld, or the median meld we had was 30, which is extremely high. And our protocol has been that every patient, of late we have actually started admitting the patients 3 days in advance, and we repeat the RT-PCR twice. But earlier we were actually, and if you see in the last 1.5 years, a lot of guidelines have changed. ICMR guidelines came up in last April. There's a Liver Transplant Society of India which has recently come up with some guidelines, but nothing is really solid. So what we are following is every patient we do IgG, IgM and RT-PCR and HRCT test. Now the problem with this is initially we found some patients, they became IgM positive and they took a lot of time to become IgM negative. So then some of these sick patients, when after a couple of weeks, when we found IgM was not becoming negative, we went ahead with transplant. And if you look at these HRCTs, most of these patients are fluid overloaded, and invariably the report will be CORADS 4 or CORADS 5. So there's a lot of confusion. So we have to get the pulmonologist, the anesthetist, and a lot of discussion with the intensivist. And finally, we go ahead with surgeries in all these sick patients. In fact, I would say logistically, we have probably lost about 1/3 of the patients because of logistic reasons, and we could not operate. Now, when we analyzed our patients, we actually had a publication in American Journal of Transplant. After that, we have had a lot more patients. Patients who had COVID and came up for transplant, there have been 10 such patients. And in these 10 patients, the results have been pretty good. 9 survived and they actually had a very smooth recovery. One patient we lost, he had a bile leak, but then bile leak got controlled, but somehow suddenly the infection flared up and we lost the patient because of lung complications. Post-transplant, again, we have had 10 patients in this series of 95 over the from last May to this May, since our team moved out to AIG. In this 95 patients, 10 patients post-transplant had COVID. And these patients, out of this, we actually lost 3. And they were unfortunate patients because 2 of them had been discharged from our care. We keep them in Hyderabad for about a couple of months. They went back to, one of them actually was from Nagpur, other one was from Sholapur. They had lot of COVIDs in their family, and basically they had to go back because they had no option. And once they went back, they had COVID and died. One patient from Hyderabad also we lost. There also the family everyone was COVID positive. So they were basically very unfortunate patients. Now we have 2 recent patients who are still requiring high flow nasal oxygen. In fact, one patient is admitted in Bhopal and another patient is on the way. He will probably reach today night. He is from Raipur. Now, this, yes, if you look at these patients, probably in the early phase, they have a little higher mortality, but later on, the mortality is not much. We, in fact, retrospectively looked at our previous 365 patients, in the last 4 years prior to this last May. In this 365 patients, we actually had 20 patients who had COVID, but all of them recovered quite well and there was no mortality. The numbers may not be correct because a lot of patients, when they have COVID, they generally hide it and don't inform us. So in a nutshell, what I would say is the patient behavior is probably the same as that of general population. Mortality probably is less. Infectivity rate is the same.
Thank you, Bala, for this very optimistic picture in these very gloomy days. I think as you follow the right protocols, as you say, we can still tackle and do complex surgeries like liver transplantation. One of the new drugs that is creating a lot of excitement, and I think it's come in suddenly and probably can spare us from steroids, is a drug called baricitinib. There's been a big paper in the New England Journal recently on this and a lot of thinking whether this should be used routinely. So we'll ask our head of pulmonology, Dr. Vishwanath, what he thinks about baricitinib and whether it should become a for routine treatment.
Yeah, so there is a lot of interest on this new molecule baricitinib in the recent 2-3 months actually. This came up after this recent trial which was published in NEGM. This is not something very new. This has been in use in the rheumatology practice for last few years actually. In rheumatoid arthritis, in fact, it has been used in other immunological conditions also as an steroid sparing agent or in patients who are resistant to steroids. Baricitinib was being used. The interest came up on this molecule when artificial intelligence algorithms showed that JAK-STAT pathway is one of the target where you can attenuate the cytokine storm. Then subsequently there were some case series and publications which came up which showed that there was improvement in the oxygenation when baricitinib was used, and also there was improvement in the inflammatory markers. So that led to the designing of a large randomized control study which was published in NEGM in the month of March. In this study, which was a double-blind randomized control study, patients were randomized into remdesivir plus standard of care versus remdesivir plus standard of care plus baricitinib in some of the molecule, and there were 500 patients in each of the in this study. What they have shown is that in patients who were on baricitinib, there was a significant decrease in the duration of the hospital stay and significant decrease in the oxygen requirement. It was seen that in patients who were on high flow oxygen and patients who were on non-invasive ventilation, the duration of hospital stay was 10 days, whereas in patients who were not given baricitinib and only standard of care, the duration of oxygen requirement and the hospital stay were around 18 days. So almost there was a difference in the stay of almost 8 days, which was very, very important actually. And also this trial showed that there was a decrease in mortality. Though this trial was not powered to look at mortality, they have shown that there is a decrease in there is a trend towards decreased mortality. So now based on this trial, I think now in the next few months to come, it will have an important role in the management of the COVID-19 patients. So this drug is given as an oral tablet, 4 milligrams, and it has to be taken for 10 to 14 days or till discharge, whichever is earlier. It was
when do we start it?
so in patients who are on oxygen supplementation, basically.
Okay.
Patients who are on like the standard of care for patients who are on oxygen is basically giving remdesivir plus dexamethasone.
Yeah.
So when you start dexamethasone and see that the patient is not improving in 24 to 48 hours and your inflammatory markers are high, that is the time to add baricitinib to these patients, and it has to be given for 10 to 14 days or till discharge,
Okay.
whichever is earlier.
Okay. So thank you, Vishwanath. I think this is very exciting news, especially because baricitinib used to be very expensive, and fortunately few Indian companies have now come out with a very cheap form of the drug. So I think that's something that is going to be accessible to all the physicians, and it's less harmful than steroids. So another good news about using
The
baricitinib.
side effects are also much lesser. In the NEGM trial which was published, they have not seen any serious side effects. Only thing to be remembered is there is increased incidence of herpes zoster infections,
Yes.
for which we need to add valcyclovir prophylaxis, which is 1 gram once daily,
Yeah.
and also the pneumocystis prophylaxis.
Okay.
But the serious infections, bacterial infections, are much lesser compared to the steroid arm.
So that's a drug we should look forward to in future. So thank you, Vishwanath, for that. And we come back to Bala because it's very interesting. Our institute has had a huge experience with methylene blue. A paper is coming on this where they have shown that use of methylene blue, which is not reported much in the literature, is actually decreasing the patient's need for ventilation and so on. As we discussed before we started this discussion, this is not only evidence-based but experience-based. So one of the experiences our institute has been methylene blue. So we'll ask Bala, because he's been following some of these cases. What's your opinion on this, Bala?
Being used for ARDS as a last resort, a lot of patients have actually been showing excellent recovery. So just as a extension of it, it was used in COVID. It probably acts by inhibiting the free radicals, the free radical oxygen species, nitrogen species, and it probably has an antiviral effect as well. It acts against the AC and the receptors on the antigens, and it inhibits the kallikrein system. Now, it should be given early, and it is in our institute, it is being given with COX-2 inhibitors. It has been tried in about 300 patients. The data is being evaluated, and surprisingly, the results are pretty good with decrease in the ICU stay and lesser mortality and quicker recovery.
Yeah. Thank you, Bala. I think this is a drug that I'd advise all the practicing doctors to look forward to. If these results can be duplicated elsewhere, it may be a very cheap alternative for very sick patients. One of the controversies that has come actually more into public and in papers in recent years is about convalescent plasma. It used to be a backbone of treatment in the first episode of COVID, and there were blood blanks flooded with this, and there was even the police helping us get this plasma. But suddenly, the Ministry of Health in India has dropped it out from treatment of COVID. So we'll ask Shivakumar what's his opinion on this, and why did this happen, and what do you think really should happen?
Yes, sir. Thing is, plasma, convalescent plasma has been a very controversial topic. Basically, earlier when we, in the first episode, we used to see that plasma was helping in patients. We used to, in fact, our experience was that we used to see patients improving with plasma, especially in the first week. But then a lot of studies have been done retrospectively and prospectively, and RCTs have also been done, especially with the largest one, that is the recovery trial, or the Indian study, that is a PLACID trial, which has been done by the ICMR, has suggested that there's no mortality benefit. There's no benefit even in terms of oxygenation. There's no benefit even in terms of duration of hospitalization. hospital stay. So this was probably, the set of patients or probably the trial was not probably powered appropriately. So maybe that is the reason why they did not get an appropriate results. But then when we come to our hospital experience, when it has been initiated at an appropriate time, it basically convalescent plasma works well if it is given in the early first week. First week when the patient is diagnosed to have COVID and probably having the first initial symptoms of fever or maybe mild oxygen requirement, yes, at that point of time it might work. But later on, even if it is administered, maybe it might not work. So that is the reason why I still feel, though the studies are against plasma, maybe the jury is still out. Maybe it has something, maybe some other studies might come out saying that it might be beneficial. So let's see, let's wait for further evidence. But personally, I feel, yes, we should be administering plasma at least in the early phase of the illness.
That's a very good point, and that's actually the reason for these conversations to go on, that there's some evidences which are very contradictory, especially about plasma. You look at papers, in New England Journal itself produced 2 different papers, one from China saying it's useful, one from US saying it's not, and then there's a large observational study which came from Mayo, over 10,000 cases where they found it to be of some benefit. So there's a lot of controversy. So I think we should not go by a single evidence here. Our experience has been that if you give plasma very early, but especially very important if you check the antibodies, S1, S2, neutralizing antibodies, and if they are high, above 250 especially, then the chance of this being useful is high. So I would not, from our institute's sake, say we drop out plasma still. I think there's still chance for, there's still some benefit of using it very early, especially in those patients who have very high levels of antibodies. Corollary to this is the monoclonal antibodies that recently Government of India actually has approved from companies to come in. Again, there's a controversy here where the monoclonal antibodies from US is going to help patients here because we now know that variants are occurring. There is some evidence it may, but we're still not sure. So what has happened is our blood bank department has come up with a very novel idea. So what they're doing is that instead of giving monoclonal or even plasma, so giving 200 plasma from a single patient, they will take 50 ml of plasma from 4 different patients. What you have is a polyvalent, high dose of polyvalent antibodies in our patients taken from, and this seems to help. This is something that we should work on, do studies to see if it's going to be beneficial. Thank you, Shiva, for clarifying that. And so the other new disease that is, I think before we go to that, we have something very interesting that has come up, and this is unfortunately labeled the black fungus. I think we should not use this term because this is a media term. Mucormycosis has suddenly become rampant in the country, so much so that in our state at least it's declared an epidemic. We're seeing many cases. ENT surgeons are seeing, they're operating on 2 or 3 cases every day. It's been estimated that there are over 5,000 cases in our country. Amphotericin B has gone off the shelf, very difficult to get it. These patients have a very unfortunate sequelae in terms of losing their eye, sometimes cerebral lapses and so on. So to know more little about this very hot topic, we'll go to Jagdish, our internist, to tell us what's current in this.
Sir, as you already quoted, this is a wrong nomenclature, maybe black fungus. But this black fungus, the so-called mucor fungus, it was existing before also. Now that it is very rampant, the incidents have shot up because of various reasons. So all the clinicians, we understood or we claim that the pathophysiology it could be because of the injudicious use of steroids, as it was discussed by Rajiv sir. I think after the recovery trial, and that was a passport for everyone to consider. Steroid is the only treatment for COVID, no doubt. Steroid is very important, but when to use, how to use, and how much duration is the key point using steroid in this COVID. I think coming to black fungus, there are almost 27 species. Among that, most common is rhizopus, the other is mucor, the other is actinomucor, the other is rhizomucor. And there are other few very difficult terminology like Cunninghamella and Apsomyces and Saxenia. So it's almost 27 species. Among them, we commonly see is this rhizopus, which is the most dreadful. And coming to what it actually does. See, we have different symptomology. Either we hardly see inpatient patients, but after patients discharging, we see a lot of people coming for within 1 week or 2 weeks follow-up. So this follow-up patients, what we notice is the most common symptoms they are presenting, either pain in the eye or watering of the eyes, or nasal discharge, let it be a bloody discharge or a blackish or watery discharge from the nose, or even pain or numbness in the cheek. So this is most common presentation, or it otherwise called as rhino-orbital cerebral mucormycosis. We also have seen other mucormycosis which is infecting the lung, which is called as pulmonary mucormycosis. And there are other incidents of gastrointestinal mucormycosis and cutaneous mucormycosis. See, all these conditions, particularly these fungal infections, are seen in all the immunocompromised patients. So in COVID, because of injudicious usage of the steroids as well as uncontrolled blood sugars, so this the literature has clearly proven that 90% of the patients of mucormycosis are immunocompromised. Among that, 83% were uncontrolled diabetics. So I think for this particular reason, right from beginning, in AIG Hospitals, we formed up a team, euglycemic task force. We make sure that all our inpatients' blood sugars are taken into control with the physician and endocrinology team at the best. So I think the incidence from our hospital has reported to be almost nil. So, but we have a wonderful ENT department where till now we have gathered around 50 plus cases, which are been, I think around 48 or 49 cases are the cases which we have got from other side, particularly from peripheries, where they have this, the clinicians, whoever, they advise very injudiciously steroids. The other thing is patients themselves taking the steroids at the very early part of the disease. I think so far this is what we assume. The other important things are, I think, certain practices like nasal lavage, allowing these organic substances into your nose. Maybe that already COVID is known to have a pathophysiology where your nasal epithelium and your defense mechanisms are at a toss. And we are exposing this particular compromised area to different organic substances also could be one of the thing. So I think still the pathophysiology yet to understand. Keeping these two strong reasons, every doctor or every clinician should consider a screening CTPNS either in the hospital who are having longer stay or a hypoxemic situation, or even at the discharge. We have to compulsorily ask them to come back if at all they notice any of this symptoms, because though it is rare, but it is very dreadful disease. Once you contract mucormycosis, dealing with it might be very tough in this scare scenario.
Yeah, so thank you, Jagdish. So it's prevention that's very important, and some very interesting data on oxygen. There's some view that maybe humidified oxygen, the water in the oxygen is spreading it. And there's one interesting study that's coming in from Rajasthan saying that those people who are using oxygen in their homes are more likely to develop than those who use it in the hospitals. And those people who are being treated in new hospitals, the newer ones, have less chance than in the older hospitals. This may be because the oxygen tubings itself may contain this, and also there's been some diversion from industrial oxygen to medical oxygen.
Sir.
And industrial oxygen, of course, can be contaminated with mucormycosis. So all many interesting facets. I think we still haven't unraveled the disease completely. But as you said, unfortunately, one gets it, it can be dreadful. So one has to be very careful. And nowadays, if anybody comes with sinus symptoms or little lacrimation or things like that, I think suspicion gets very high.
High index
and hopefully, this is not a transmissible disease from person to person. That's something which is very fortunate. And I think that is one positive thing about it. Thank you, Jagdish, for clarifying that. So what happened about the vaccine was that earlier phase, a lot of people were hesitant about taking the vaccine. And then came the second phase that now everybody wants the vaccine. There are a lot of recommendations. In fact, the recommendation for vaccine is becoming more than recommendations for the beds. So the vaccine has become so very important. But there seem to be some small contraindications for vaccine. So we'll ask Dr. Manu Tandon. Well, Manu, what are the contraindications whom we wouldn't suggest vaccine?
Yeah, but first let me tell you that vaccine for COVID, I think, has been one of the success stories of medical innovation, as far as I know, because it has come out so rapidly and with efficacy rates of more than 75% upwards with the different vaccines, I think it is a success story. Unfortunately, there are many fallacies that are associated with vaccination. I don't know how they were transmitted through the social media. That has swayed the public and sometimes even doctors from avoiding vaccination. What I'd like to clarify in the next few minutes are the absolute contraindications, as well as just clarify or clear a few of the myths that are associated. First, it has now been approved for all lactating mothers. I'm sure once the trial in pregnancy and children which are on way are on, it is going to become a universal vaccine. So what are the contraindications? There's only one absolute contraindication, and that is if you have already shown an anaphylaxis to one of the constituents of the vaccine, then you will avoid it. Few things a patient should know, because Rajiv has told you that how COVID produces thromboembolism. There have been studies which have shown a risk of thromboembolism with the vaccine. Now this is very, very minute, 3 zeros and 4%. The benefit far outweighs the risk. But here I will tell you a simple guideline for all treating doctors. If a patient is prone to thrombotic episodes and he is on acetrom or one of the anticoagulants, then you should see that his INR is maintained between 2 and 3. Less than 2, you are prone to thrombosis. More than 3, you are prone to bleeding. The bleeding, the worst that can happen is a hematoma at the site of the injection, which is really nothing very remarkable. The other thing is that what about the use of antiplatelets? Even with dual antiplatelets, there is no contraindication for the use of vaccine. You continue your antiplatelets, you take the vaccine. So as far as I am concerned, and I'm sure literature will back it up in the next few weeks or months, there is just one absolute contraindication: anaphylaxis or known allergy to a constituent. Otherwise, it's a universal vaccine. And as Nagi says, the demand for vaccination, as awareness has increased, the demand for vaccination is going to increase, and hopefully that is the best way we are going to achieve, along with our social behavior, away from this pandemic. That's how we are going to get rid of it.
Thank you, Manu, for I think vaccine the cornerstone. Hopefully, with so many few contraindications, everybody can take it. We come to the last part, and this is a very interesting development that has occurred probably in the last 1 week. 2DG, 2-deoxy D-glucose, which is an Indian drug made by the DRDL and of course Reddy Labs, has come up and it's created a huge awareness among the public, and we keep getting requests now. People say, why don't you start on 2DG and all. The knowledge about this drug is not so clear still because it's very early. So we asked Dr. Narasimham to tell us about this drug and what he thinks about it in terms of using it in practice.
Thank you. First of all, let's look at what is 2DG. It's 2-deoxyglucose. All of us know glucose is a 6-carbon sugar, and one of those carbon in the second position, the oxygen is depleted. That's 2-deoxyglucose. Now, the biggest advantage of this is in any kind of treatment, you look at how can we exploit the therapy of a disease compared to a normal person. In you and me, when we need energy, it comes from mitochondrial respiration. ATP is produced by oxidative metabolism. But tumor cells and some of the infected cells predominantly rely on glycolysis for energy. So glycolysis, as you know from good old days, glucose enters the cell through GLUT receptors and then it undergoes glycolysis. Here is a compound that exactly looks like glucose, but it's a decoy molecule. It enters the cell, but thereafter it doesn't participate in ATP generation. With the result, certain cells, like it is, for example, certain pancreatic cancer, glioblastoma are all cells which predominantly depend on glycolysis. Similarly, virus infected cells depend on glycolysis, and the virus also for replication uses the energy metabolism predominantly through glycolysis. So in effect, you are depleting the cell so that the virus cannot replicate and there is an increased apoptosis of these cells, and then we'll die. But the problem with this compound is it has to be taken in huge quantity as sachet, and then the bioavailability of this at that particular lung tissue is still to be studied. So this is the reason why clinicians, we are very simplistic. Okay, this molecule annuls this, therefore it will work. But it's not that simple, because what you show in a Petri dish has to show as a clinical outcome, and that is what we are waiting for. But there is a theoretical possibility that this drug is going to work and deplete the cells. How it is going to work in the lung tissue, the clinical trials are going to show.
Thank you, Nageshwar. I think this is a good clarification. We are hopeful, and hopefully the company will start a clinical registry so that when large number of people, say 10,000 people use this drug, we'll know whether it's effective or not. So we come to an end of these conversations with all experts on different areas. You realize that although this was an easy conversation, there's a lot of science behind what was talked, and we hope that this science will help those who have watched at least to improve their practice of treating COVID patients. What happened is we have a lot of questions coming in. In fact, I've been handed over a big bunch of questions. This also testifies to the popularity of this program, large viewership and a large number of questions. Unfortunately, we have run out of time. We won't be able to answer this. So what we'll do is we'll hand over these individual questions to our consultants who discuss this in their various expertise, and we'll send emails in terms of answers to those who have asked these questions. Finally, I'd like to thank all our consultants, all the senior consultants for taking part in this, for being so active in this area, for helping so many COVID patients. I'd like to thank also, we have had a huge sponsorship from Micro, who made this series very popular. I'd like to thank Jairaj and Krishnaji for the participation in this. And finally, the final part is we are also releasing a patient guide, because we find one of the deficiencies in this has been the patient guide, and this has been discussed before several times in our discussions, that don't take steroids and so on, things like that. So we have this guide which comes out in 3 languages. It comes out in English, Telugu and Hindi, and hopefully is also available in digital form, and hopefully some of this will reach the patients because it helps them in the proper care. So this is available digitally at the AIG website. Again, thank you all. We sign off from here, and hopefully if some very dramatic new developments occur, again we'll meet in this forum. Thank you very much.